Hello, friends. Good morning. Welcome to Pediatric Basics. I am Pawan Sharma, one of the pediatrician. So this is our second part of congenital heart diseases. I think as a series, what we can think or what we can say is this is approach to the child with possible congenital heart diseases. This is a little bit long video, maybe about 10 to 12 minutes. But I think sometimes learning do gets boring, but I'm sure when we finish this, we will all have a take-home messages, and I have tried to make it more interesting by including some cases. So let's see. Yeah, let's start with some case scenarios. So, if you have been a pediatric clinic, you might have come across similar situations. But if not, as a medical student, you might have, you will probably get some opportunity to look similar kind of situations when you visit the pediatric wards and the neonatal unit. So, a term baby who has had a normal baby check get discharged home, and roughly around day 4 or 5 of the back is brought back to accident and emergency, completely shocked, very pale, extremities not feeding, and then on examination you see a really unwell baby who can't even feel the pulses, the brachials and the femorals. Okay. The second scenario is where a term baby who is on the postnatal ward and mom comes and tells you, "Oh, my baby looks a bit different than the other baby. Is completely boo, but otherwise well feeding and does not have any problem like breathing difficulty or anything." The third situation, or many of the third situations, you can say a few weeks old baby, roughly about 8 to 10 weeks of old baby, is brought to you or referred to you by one of the primary care center place, that the baby is not feeding very well, is losing weight, has got respiratory distress, and mom is quite concerned about all those things. And then I think the most common scenario as a pediatrician we see is a referral from the primary care, where the primary care center physician or a practitioner has noticed that there is a heart murmur, and they would like us to see the child and give our opinion what are the possible reasons behind it. I would like you to think about this, what possibly is going on in all different situations, and towards the end I'll have a brief talk about them, what has happened. Again, it might sound a little bit boring when we talk about the algorithm of the history taking, but I love it. So, the presenting complaints, history of presenting complaints, the past medical history, allergy history, family history, drugs and alcohol history, the social history, they are really important in terms of the overall assessment and coming to the diagnosis. And that's why this algorithm. Now, thumb rule, when I say that whenever we are going to examine a child or any patient, to be honest, is the key thing is observation. So before I even take history, I would like to see how the person or a child is well or unwell, and is this child in need of any help before we even take history. So you might suddenly notice that a child is in respiratory distress and he will need some help. So give a shout and seek for help for that particular situation. But apart from that, observation is really important in so many situations. You can notice many findings. Like I said, well or unwell child, a child having respiratory distress, a child looking pale, is there any visible jaundice? Are there any visible rashes or any external bleeding? So similar kind of things are really important to notice. And while we talk, we'll go through the symptomatology as well as the maternal history, which can be really important in any of the congenital cardiac problems. Let us try to simplify things in terms of our approach. So, what can go wrong with the congenital heart diseases? They can be cyanotic heart diseases, so they will present as cyanosis. Uh, they can have complications which are heart failure, infective endocarditis, They can have neurological symptoms as a complications, and then the growth failure and milestones. So primarily our history taking and examination should be based on this symptomatology, which will help us to arrive at a diagnosis and the problems. Many of the maternal conditions and maternal medications, they do have a significant effect on the fetus growth and development, and as well as abnormalities, and congenital heart diseases are not an exceptions. So there are few mentioned on this chart, like diabetes mellitus, maternal SLE, maternal phenylketonuria, rubella, and mumps. Why don't you think about what all this can lead to, which different kind of congenital heart diseases in a child, and then we can then proceed to the next slide, or and see what were your answers. Of note that many of the countries, they have a system of what we call as a pediatric alert, where antenatally detected problems in mother are being reported to pediatrician well before the birth of a baby, so that you are aware about the problems and you can take necessary actions and steps as soon as the baby is born. So here we go. You can see all of them there, but maternal diabetes is very common, and it is important to see what effect it has on the baby. We call them as infant of diabetic mother. We'll discuss that in a separate video. So list of some of the medications so which can have effect on the fetus causing congenital heart diseases. Do you know any of them? So your answer will be in the next slide. Here you can see the list of conditions where there are chromosomal anomalies and syndromes causing or having the congenital heart diseases. They're sometimes very specific to them. So that's really important, because you can have things look at vice versa. So if you find a heart condition, then you look for features of the syndromes. Or if you find a syndrome, then you look for the features of the respective heart diseases they are having. One thing of a note usually is if there is one congenital abnormality, then it is always better to look for any other possible abnormalities, because they can be more than one abnormalities in a child. Do you know the various heart conditions, these syndromes which are seen in the list? And if you know, think about them. Your answer is in the next slide. Heart failure. Now, as a medical student, as a trainee, we are always very much interested in knowing different kind of heart murmurs, how to detect them, listen to the heart, and then try to come to the diagnosis. I think that is important, but more important is identification of complications of heart diseases, whether it is congenital or acquired heart diseases, because that will help us to help these patients in terms of what exactly is going on with them. Now, infant and young children have a little bit different symptomatology as compared to the older children. So as you can see in the list here, breathing difficulty, reduced feeding, reduced activity, cold, clammy extremities, sweating, especially over the forehead and the scalp. Sometimes they will have the peripheral cyanosis as well because of the reduced circulation. Edema is uncommon, but they can have the edema, which can be seen more over the face rather than other parts of the body. And then growth failure because of various reasons. But sometimes you might even find that actually the weight gain, which is because of the fluid accumulation because of the heart failure. For older children, it could be something similar to what we see in adults, like exercise intolerance, existential dyspnea, orthopnea, paroxysmal dyspnea. It will be interesting for you to learn about them, but I can talk about them separately. Tiredness, lethargy, GI symptoms are uncommon, but that can happen because of various reasons, especially when they are on some medications as well. And edema, which is characteristically pitting edema, weight loss, or there could be weight gain because of the edema. What do you see in picture 1 and picture 2? So picture 1, I'm sure you might have spotted if you've seen that before. So there is a cyanosis, and then this particular man, unfortunately I did not get a child's picture, as having clubbing as well. In the second picture, there's a baby. You can see the lips Probably a little bit of a ear. The face also looks bit, and the fingers and the hand, they look blue. So this baby is having a central cyanosis. Cyanotic spells, or as they call in US as death spells, are becoming uncommon more because of the medical advances of antenatal diagnosis and early diagnosis in infantile period. This is the situation which happens to patients with congenital cyanotic heart diseases, especially like phallostatology. They become severely unwell with increasing respiratory distress, worsening of cyanosis, increased intensity of heart murmur, convulsions, and sometimes even, if untreated, can lead to death. As a bedside, hyperoxia test is one of the useful tests. I don't remember when I did it last time in my practice, might have been ages ago. But any newborn presenting with a significant cyanosis, and if you want to rule out whether there is a cyanotic heart disease or there is something else going on, this is a test we can do. So the infant is placed in 100% oxygen, and you do a right arterial blood gas, and depending on the numbers of your PaO2, then you can say whether there is a cyanotic congenital heart diseases or not. Now, important thing is not use the oxygen saturation levels to do these tests because they are very unreliable. Reliable. The most important is doing it by blood gas. Another thing to look from the point of view of significant importance is the features of infective endocarditis in patients with congenital heart diseases and acquired heart diseases. This is, I believe, one of the interesting topics with the medical students and trainees too, because there are so many features to look at for. So as you can see in the picture, there is finger clubbing, there is genuine lesion, there are splinter hemorrhages, rot spot, then they can have changing heart murmur, worsening of or development of heart failure. Splenomegaly, pallor, and pyrexia are the features. Microscopic imagery is also important. We don't talk much about it. So keep an eye for this whenever you are assessing a child with heart diseases. These are some of the common congenital heart diseases. We'll talk in our future videos. So these are left to right shunts, ventricular septal defect, patent ductus arteriosus, atrial septal defect, and AV canal defect, cyanotic congenital heart diseases like phallostatology and transposition of great arteries. So keep an eye. Few key points. One is a neonatal presentation of a congenital heart disease is highly likely to be a duct-dependent lesion. Number two is a newborn or an infant and presenting as a shock. One should think about a duct-dependent congenital heart disease and act accordingly. And three, although we did not discuss any investigation, but a normal antenatal scan, a normal X-ray chest, and a normal ECG does not rule out any heart disease. Okay, coming back to the different scenarios we talked about. The first one, let's see, the heart murmur referral to the um, pediatrician. Most commonly, they are what we call as an innocent heart murmur or physiologic heart murmur and do not have any underlying problem. But when we talk about the significant problems, the number one, which we talked about, the term baby who is shocked within first few days of life, it is highly likely to be a duct dependent lesion, and this particular child was having a severe coarctation of aorta with hypoplastic left heart. The second baby is a cyanotic baby, has got central cyanosis, and this baby's diagnosis was transposition of great vessel. But fortunately, he did not need any immediate medication and was safely transferred to the tertiary center. And the third one is the baby who has got recurrent chest infection and features suggestive of growth failure or heart failure, has had ventricular septal defect. So this is kind of a common presentation of a significant left to right shunt. It could either be VSD or a PDA. So you might have some more cases on your side, so please do let us know.